our name spread. We gave a position statement by the Indian Psychiatric Society that homosexuality, lesbianism, etc. is not a disorder, and it's a normal form of sexuality. It is on the basis of that position statement that the Supreme Court said that Section 377 is decriminalized. So that was a very big achievement that we did. Coming now to conversion therapy and why psychiatry shouldn't support it. We see 4 or 5 variants of this version in our practice. Whenever any parent comes to know that their child says that I think I belong to the LGBT community, there is shock, there is denial, there is anger, there is a little bit of bargaining. There's a thought that this is a phase, it will go away. The acceptance takes anything between 6 months to 20 years. I work in schools, so I have many children that come to me between the age of 14, 13, 14, 15, right up to the age of 17, 18. The schools now have up to 12 standard. And they come and tell me that, sir, we think we're bisexual, we think we're gender fluid, we think we're lesbian, we think we're gay, and we would like you to convey that to our parents. I very often tell children that there's nothing abnormal in what you think. Point 1. Point 2, let your sexuality develop in the age of 20, 22. Let's see what you feel throughout. I'm not saying that you're going to change, but there may be slight variance in the way you feel about things. I've had a lot of people who came to me at 14 and said, I'm gay. They've come to me at 18 and said, I'm bisexual. So I said, let's see how your sexuality develops. And then once you're 18, 19, 20, you're very sure, that's the time you could talk about it to people, parents, etc. A close group of friends could know about it. Because very often the first reaction of parents are that this is because of his peers. And his peer influences are converting him into this, which is not always the case, never the case rather. So one is, I get the first form of people who come for conversion therapy are parents. They bring their son or daughter. I am using the terms which parents use so that you realize. सर आप इसका 4-5 सेशन लीजिए और ब्रेन वॉश कर दीजिए कि उसका सोच चेंज हो जाए. And I very often tell them that that's not my job as a therapist. I can hear him out, I can hear her out, I can decide, I can speak. And I'll tell you what I feel, but my job is not to change your thinking or his thinking. I've had parents who told me, are there any doctors who specialize in this? And I said, sadly, no. Is there any medication we can give so that this changes? Particularly, any gynec can give some hormonal therapy, or any other doctors can give some injections, so that I've had parents who've got a series of hormonal tests done because they feel that these feelings come up because of certain hormonal deficiencies, and they feel that giving certain hormones could probably help change all this, but that's not the case. I've had a number of mental health professionals who come to me and said that we feel a little uncomfortable when we handle patients from the LGBTQ+ community because we feel we're not equipped. I always tell them you have 2 choices. You can learn, study, get equipped, or just clearly put up your hand and say that I don't handle these cases. But please don't handle them wrongly. Please don't succumb to societal pressure, parental pressure, referral pressure because somebody you know has referred, and try and show your prowess that I'm going to make a change here. It's all right to say, I don't handle these issues. Please go to someone who can handle it better. But don't handle it when you don't know anything about it. I always remember another version of this. Parents who are supportive, but society doesn't allow them to be supportive. I met a parent whose child presented to me at the age of 16 first. Initially as feelings, a belief that he was gay, and then feelings of gender dysphoria, that I do not want to be male, and I think I would like to sort of convert myself to female, and at the same time feeling that he was gay. Initially I said, we'll wait till you're 18, 19, 20, see. They didn't come to me after that, so I don't know what happened. At the age of 20, the boy came to me and was undergoing hormonal therapy as prescribed by a doctor because he wanted to look feminine. He had undergone laser for his hair, beard and other hair. And I very well remember the parents when they came to me. I spoke to them, I told them that it's very difficult for you all, I totally understand, but he needs your support, and if he's going to turn into a she and later change gender, sexuality, name, will need your support all the more. I even showed them an ad made by Starbucks which supported change in sexuality. They were from a place slightly outside Mumbai called Palakkad. And they told me, sir, we love our son. We want him to live his life the way he wants, in whatever way he wants. But tell him not to return back to Palakkad like this. Tell him that he can stay in Bombay in a space where people accept him. We will visit him. But if he comes back to our village, we'll be thrown out of our village. It may even lead the two of us wanting to end our lives because of the shame. But at the same time, I understand it's a changing world and he has to change, and all that is fine with me. I'll support him. But can you counsel him that he has to also look at it from our cultural perspective and accept that he can't come back there and express himself freely because the people in the village are not going to accept it. Tell him you be in a city where they accept you. I have no problem. Go to Bangalore, go to Mumbai, go to Pune, wherever he feels accepted. Let him study there. We will come and meet him. We may even shift there to help him out, but he can't come back to the village. This is a second form of where the parents are supportive, but sometimes the society doesn't allow you to, be what you are. You also get a third form of people who come. When I say people, I mean relatives, parents, etc., who bring the person for conversion, where one parent is very accepting and the other parent doesn't accept, and the other parent feels this is a problem. In such cases, it's the supportive parent that usually moves out with this person. It could lead to a rift in the marriage at times. Over years, acceptance in the other parent may come in, may not come in. Siblings are usually very supportive because they belong to an era where they are aware of all this. A lot of younger mental health professionals work with the LGBTQ+ community and are very, very supportive. There are times when I've been asked, am I a queer affirmative therapist? And I say, no, I don't have any training in that area. I say, I prefer to just call myself LGBTQ+ friendly. I said, I'm not trained in that area, but yes, I can handle certain issues. And if I feel you need someone very specific, we'll refer you over there. Conversion therapy should not be allowed at all. In fact, the Indian Psychiatric Society has passed the statement that it's absolutely illegal and shouldn't be done. No form of treatment should be provided for homosexuality, lesbianism, etc. It's not a disorder. But there are still people thrive on doing this. There are people who say we're doing behavior therapy to convert someone's sexual preferences, which will never happen. I mean, behavior therapy is being done, but the change is never going to happen. Many a times, whenever we speak about this, the worry is, I remember as a psychiatrist when I started working in this area, it's only when I spoke to individuals who actually work with these people and this community that I realized that there's so much of pain they undergo. I never knew that before. Because patients never came to me, so I never knew. When they came, I realized. And then I realized that there are two facets. One facet is belonging to the community, which is one aspect. Someone told me, what about mental health issues in this community? And I said, people who belong to the LGBT+ community are as normal as you and me. Their mental health issues are as good as the ones I have and you have. They also have depression, they also have anxiety, just like we all have. It's only that the factors, the antecedent factors and the factors causing this could be slightly different compared to us. I said, we may have a strict boss that irritates us, they have a community that's against him. I said, we may have problems in a marital relationship, they have problems in their own relationships. We're also a couple, they're also a couple. We have breakups, they have breakups. We feel suicidal, they feel suicidal. The factors differ a bit. Finally, the biology, brain-wise, is to say the methods of treatment are similar, but the factors in therapy may matter. It's very, very important that whenever you see a colleague, friend, senior talk about conversion therapy, please report, please complain, please pick up the phone and tell that person that what you're doing is bullshit and you shouldn't do it. And if you don't stop, we'll complain officially about it. There are a lot of bodies you could complain to. There, you could file a police complaint if you need to. Today, even our police force is fairly sensitized to a large extent, courtesy the effort of a lot of NGOs that work in this area. Sometimes you will always have some people who are not sensitized and you can't do anything about it. It's also important that you educate others. So if you meet students, colleagues who are probably struggling on how to deal with these issues, teach them. Even in an MA psychology course, I always feel you need to have one module on mental health issues and LGBTQ+ community counseling and other things, which I don't see in many MA courses. Maybe it's coming now, but in counseling psychology courses, you need a module on this. It's very, very important to realize that a lot of people who engage in this so-called conversion therapy do it because of three reasons. A, they are not aware. B, they choose not to be aware. And C, both. So A, we make them aware. And if they choose not to, we make sure that they choose yes and get awareness. I remember some years back there was a complaint made against a particular doctor for trying certain treatments for conversion therapy, and the matter came to us. And the committee was asked, should his license be cancelled and should. So we said, don't cancel his license. Make sure that he attends a 1-year course and learns about it, so that he's aware. He's told that now in future if patients come to you, your approach has to be this. If a second complaint comes, we'll make sure that your license is cancelled. We didn't do it to help him. We said that it's fine, let him learn. He said, I was not aware, I didn't know. Fine, so you learn. Of course, he now works with these patients, he's aware. We have a lot of senior psychiatrists who don't want to change their views. It's fine. We tell them, sir, it's absolutely fine, you can hold on to your views, but then don't deal or treat these patients. Send them to other people who manage them. You can straight away say, I don't handle these cases. Don't at least spread the wrong information. And now I think fairly enough in the city of Bombay, even senior psychiatrists realize that this is absolutely normal, and they tell parents and they tell others. When I conduct sex education sessions for adolescents in schools, we talk about LGBT+. Earlier, schools and principals would not allow us to talk about it. Now even schools and principals are aware. So we talk about it. You'll also have some very sweet moments when you treat these patients. I always remember we were organizing a seminar on LGBTQ+ issues at Nair Hospital a few years back. And I was standing on the stage, there was another doctor standing next to me. And I had someone from the audience come up and said that you all two look very cute together. It was not a compliment that I had ever received. So I said, thank you so much. I said, and then he said, do you all belong to the community? I said, no, we're only friends of the community. We don't belong to the community. And we're both very much heterosexual and we're not belonging to the LGBT. But he said, you're doing so much work, so I thought maybe. So you'll get people who talk about that. Let's not get annoyed. It's absolutely fine because they feel, who feels for them? Someone who knows them, someone who understands them, someone who probably belongs to them would feel for them. So they feel that way. It's not wrong to feel that way. Whenever I've spoken to parents about accepting this in their 25-year-old, 30-year-old, not seeking psychiatric help for conversion, but seeking help for mental health issues, they very often gone to other psychiatrists. They've gone to around 5, out of which 4 have told them this is normal, 1 has told them no, we don't handle these cases. And then they come back. And then over time they accept, they understand. Because the parental instinct always loves their child at the end of the day. It will take them time. I'm not saying all parents are that way, but at least around 70% of them are that way. You will always have 30% who don't want to budge, which we can't do much about. The take-home message for today is, some of you are working professionally, some of you will work professionally, some of you will go ahead and work with this community. If you can't do anything for them, it's fine. Don't end up hurting them. That's the first message. They've had enough of hurt that's come their way. 2, if you can do something for them, do it with an open heart. 3, get more knowledge, get yourselves more aware about this. It's an evolving field. So there's a lot of new things that keep coming about it on a daily basis. What started off as LGBTQ+ is today a very huge umbrella. So get aware about a lot of things which are being used in this regard. In India, sexuality itself is a taboo. It's not spoken about. So LGBTQ+ is going to be not spoken about more. But we have to make sure that we have more open conversations about this. Anyone who's feeling homophobic needs to be taken to therapy for homophobia. And that needs to be quelled. That's very, very important. Because there's no way you're going to run away from this. This is going to be there with us. A lot of people ask me very often as a psychiatrist that in a lot of people who belong to the LGBTQ+ community, child abuse is a very common factor that we see. And do you think that it's not pathological because it's caused by child abuse? I said no. Even the child abuse is something that happened when the person was unaware what was happening. So there's nothing pathological that's happened to the person. The act is pathological. The the abuser was pathological, not the individual that underwent the abuse. So what happens to him post that is not psychopathology that he has produced or brought upon himself or herself. I've had a lot of people who tell me that, sir, we get a little mixed up when it comes to remembering pronouns, understanding stuff. I see you can always call the person by the name if you are a little confused initially. And then later, yes, you can get accustomed to it over time. There are times I've written a certificate and the person has very politely told me that you put my pronoun wrong. But naturally I put the pronoun on the basis of the name. And I very politely said, I'm very sorry, and I've changed it, it's okay. I mean, we make mistakes, we admit it, it's absolutely fine, there's nothing wrong. I mean, I say, I don't mean any offense to you, I'm very sorry, and I'll change it, it's absolutely fine. And you might as well call the person by name if you don't want to get, tangled into that process, it's fine. But it's good to know, it's good to be aware, it's very well, you get more knowledge in this area. And lastly, but not least, I have a priest at a church where I work, and some members of the Christian community who have developed homophobia because they feel biblically it's a sin and all that, have asked the priest that we know certain members that come to our church belong to the community, and why is it that they come every Sunday, they pray, and they receive communion. Communion is what they receive during the Mass at church. And the priest asked me, Doctor, this has been asked, what do I do? And I said, quote what Pope Francis said, that if someone belongs to the LGBTQ plus community and they want to seek God, who are we to judge? They're not coming there to say anything about their community, they're coming there to seek God. And God is neutral to them, God doesn't say anything to them, so why should we judge? They have every right to seek God as much as the others. They're well behaved, they're praying, they're doing everything that others will do there, so there's nothing wrong. And let me tell you, everyone can be included. You have to first not develop a mindset. You have to first open your hearts. Your mind will open automatically. Thank you very much.
Thank you, Dr. Avinash DeSousa. Your words truly inspire us today. Now, we open the floor for the questions.
Have I encountered any patients? In the sense? See, there are two aspects here. Now, if you're talking about change in sexuality and gender, at science, we have a lot of patients who come seeking fitness for that. The fitness process is not something which is easy. That you come in, I assess you, and I give you fitness. It involves a lot of steps. So the first step is first assessing whether this is pseudo gender dysphoria or true gender dysphoria. That's the first step. Secondly, whether it's only gender dysphoria or it's gender identity disorder, and they actually want to undergo sexual reassignment surgery. The age of the patient. So if he's 18, you're telling wait a little, you're 24. In the meanwhile, you can start looking like the opposite, dressing like the opposite, living like the opposite. See how you feel. Once you spend a year or two doing that and you now feel comfortable that way, hormonal therapy is the second step. And it's only once all that is done, because hormonal therapy can still be reversed a bit if you are in that transition mode. It's only post that, once you're very sure, that we get 3 psychiatrists, an endocrinologist, and a plastic surgeon to certify that you're fit for sexual reassignment surgery, because the surgeries are long, they're not very reversible. So it's something that we have to be very careful that we take the call on. So that's how we come. So we normally, I would say, there is always a 2% group that comes back and says we're not happy, but we tell them this is something that was discussed in length prior to surgery. You can undergo a few hormonal changes if you want. And there are now, I'll tell you what happens is it's also very important when this group comes that you assess that they're not gender fluid. Because if they are, then there's a problem that comes. In gender fluid, we've seen 2 variants, and I'm not an authority on this, but I'll tell you. One is where there's what I call cyclical gender fluidity. So it could be that they feel feminine today, then masculine tomorrow. And there are some who have phases. So for months they feel one gender, and then they move to the other gender. So that's a little difficult to do sometimes, where you have to be careful.
I think as a person who has transitioned, I think I can answer this from my perspective. When somebody wants to transition, it's not like an overnight decision. All of us think through it for so long, especially because there's this narrative that what if you want to detransition? And everything is calculated. Like for me, I started hormones, I'm 1 year on HRT now. And it was not, I just didn't decide that, oh, I want to do this. Because what comes with it, like you mentioned, there are a lot of permanent changes that happen. And there is, the only safety net is that I can stop hormones. But the changes, whatever they are, I will have to live with them. So even that small statistic of people who detransition, many of them, there's this idea of detransitioning as going back to being straight or cisgender. But actually, in my experience, the kind of people who I've met who have detransitioned have only come to realize that their gender is no longer needing to be in any boxes. Like for example, if today I'm not a binary trans man, but if I live my life thinking I'm a binary trans man, then one sudden day I'll realize that my gender is no longer in the binary, it is non-binary now. Then I will detransition. That will medically still be called as detransitioning. But actually the person is still in the queer umbrella. They are just detransitioned medically because they stopped hormones. And now their idea of masculinity or whatever their queerness and their transness is no longer in the boxes of man, woman, trans, non-binary. It's fluid. That is also an idea that is actually very common among a lot of people who've been on hormones for a long time. And they realize that I don't want this anymore because my idea of gender is now not aligned with anything that society thinks of it as.
Hello? Yes. So when the trans bill came into force in 2019-2020, there was this thorough debate that, as you mentioned yourself, that first we screen if it is pseudo-gender dysphoria. And as Rick told himself, that it is not a decision that is made overnight or it is not on impulse. So don't you think another person screening or validating or invalidating, approving, disapproving someone's gender dysphoria, which can be at any point, is something that should not be practiced?
Okay, so the thing here is, see, I screen primarily for 2 reasons. One is, as a clinician, the aftermath, if he's or she's incorrect, can be very traumatic. Okay, if she or he is correct, then there's no problem. So my screening as a psychiatrist is more in case what I feel, the conviction with which you think, the thought process about the transition is unclear. So you get some patients where they're very clear. They come, I call them patients because doctors call everyone patient, it's not that. So they are very clear about everything. So there's no need to screen the other. We know this person. But there are some who say, I want to do hormonal therapy. Why do you want to do hormonal therapy? My friend told me. Have you read about it? No, I haven't read about it. Do you know what it entails? No, I don't know. Why do you feel that you want to become the opposite gender? Because I had these feelings. How often do you have it? Once or twice a day? So what I'm trying to tell you here is the screening process is more to ascertain the genuinity versus the non-genuinity. Because we don't want to put the wrong person through this. If the person is very genuine and clear, then the process is smoother. So that's the whole aim. The aim is not to validate whether your gender is correct, incorrect, or we don't tell you no, you're wrong in your thinking. No, that's not the thing. The aim is just, and also if you have to undergo medical procedures, you need a certification. That's the process. It's not, no one is going to give you even hormonal therapy without maybe 3 people certified, because the doctor also feels that it's better to have 3 opinions. It's not one person, it's 3 people. So if 3 of us feel the same way, then we think, okay, all of us think. And we have undergone some training in this. We've attended some workshops done by Niman, certain NGOs and other things. So we understand a few things about this and gender identity per se. Yeah, so from that point, yeah.
I just have one more question. There are some in Western countries I've heard that people groom their child to, because they take advantage of this entire concept. They groom their kid to be somebody of the opposite gender. So if people wanted a girl, then they would groom their boy to be a person of the opposite gender from a young age onwards. So how do we identify this?
Okay, so at least I think in India here I haven't come across much of that. But let me tell you that I met a number of individuals who we feel that in their attitude, belief, though phenotypically or physically they're feminine, we feel they're very masculine in their approach. Now, I don't think it's grooming or it's anything that's got to do with it. That's the way they are. And if you go into their families, you'll find that the entire family constellation is similar. And it's not abnormal, it's absolutely fine. So, for example, there are the sternest of, I work at police hospitals, so I've seen the sternest of police officers are feminine, very strict. You get 2 slaps from them, you fall down, very strong. But the thing is that they have a lot of masculine traits in them, but they're also feminine. So I don't think, if a parent is grooming a child from a young age to belong to the opposite gender, then the pathology lies in the parent, not in the child. And I think that will need to be handled at that point in time. Yeah. Yes.
Doctor, my question may seem frivolous,
No problem.
but I have a genuine doubt that when we speak about hormone replacement therapy for women undergoing menopause, so when this transient, phase is going on and the person is on hormone replacement therapy, are there any risks associated during the therapy and later on? Maybe increased risk of cancer or anything?
Okay, so now it depends. See, hormonal replacement therapy in menopause is very different because you're biologically female and we're giving you female hormones which are deficient. So we're trying to maintain your physiology. So there's nothing wrong there. But what happens is if you're biologically male, and I'm going to give you feminine hormones, you may have changes in the way your hip is, the size and shape of your breasts, your physical characteristics. You may have less hair on your chest as a result of this. And I'm not only giving you feminine hormones, I'm also giving you anti-testosterone drugs at the same time. Now, what can happen is the dosage has to be proper and accurate. So if patients have to know that it's going to take a year and a half, 2 years for changes to ensue. It's not going to happen that in a month you're going to change. So there's no way that I take a mega dose and I'll become the opposite gender in a month. That won't happen. So if you're looking at that, and if someone is giving inappropriate doses or high doses, the chances of ovarian tumors or testicular tumors or any other things are always higher. So it's done by an endocrinologist, someone who's trained in hormonal therapy and who monitors everything. You undergo repeated sonographies, you undergo repeated physical checkups, even MRIs of your abdomen and internal organs every year while you're on the therapy. So it's all monitored. It's not just done randomly. Yeah.
Somehow I'm related to that question, so can I answer that? So I'm Rit's parent, and you will be amazed to know Rit and I both are going through menopause. So I'm undergoing naturally, and Rit is on testosterone since the last year. In July they'll be having their testosterone anniversary. So yeah, these are special moments. So I just wanted to say this, the changes that we have seen, and of course we discuss this day in and day out. It's a joy to see facial hair. So these are external things, which do come around due to the testosterone that is, like doctor said, the dosage is monitored by the endocrinologist, and even when it will be going for top surgery, that surgeon as well. So everybody is in the loop on a very, it's like an everyday talk as well. It's not like, okay, I'm meeting the surgeon maybe in November, that is when that top surgery is going to happen, 2025. But it's a conversation. Whatever you're going through is being discussed with parents, with the surgeon, with the endocrinologist, with everybody, just to know. And yes, there are these tests that a doctor said, periodically the tests have to be done. But there is, because of all this, everything being monitored, it is quite safe. So, if people are just scared, oh my God, because that's what the first thing comes, to your mind. It's a very scary thing, where this will go now. But yes, it's a safe and proven thing. And all we need to do is ourselves learn as a parent, learn and unlearn a lot of things. So we think that, okay, I'm feminine, so all I have in my body, in my endocrine system, are feminine hormones, but even I have testosterone. So we need to know this. We need to know that we are not just like what people market it as. And a lot of issues are even around people undergoing menopause. Even for them, taking hormone therapy is a no-no, it's a taboo. Oh my God, even that is wrong. So what I'm trying to say is that anything can cause cancer, right? Today, anything on earth can cause. I mean, that's something everybody should be just, it's a joke. So we should not create a taboo around it and make it look like, oh my God, what is this? It's not like that. Yeah, thanks.
Another thing I'll just add to what she said is that your risk for tumors and other things is also highly genetic. So it's like you may probably, it's not just that the hormonal therapy started and you developed it. Probably it would have come up in your life later because of the genetic risk more than just the therapy.
Thank you, sir, for highlighting that. I just wanted to add that exactly that bit, that we constantly learn how it is a nature-nurture combination, and also that she said that's the other thing, that we don't talk about genetically modified food causing cancer. We don't talk about pesticides that enter the entire ecosystem of foods causing cancer. But somehow it becomes the conversation, particularly so when people exercise some kind of agency. I think it's usually moments of agency and choice that get shrouded with conversations around, well, do you fully know what you're going to do? Well, people make choices despite knowing what they do, and that shows sometimes the intensity of how hard they want it and how much gatekeeping they have to sort of cross. And this is also like a moment to take a pause and reflect at how many of us become gatekeepers. How many institutions does a person have to... there is risk in all allopathic treatment.
There is risk in living.
And we also call risk differently at different places. Some we give it a very beautiful name of a side effect. It's actually the main effect. It's actually an effect. But all allopathic treatment will have some side, but it will, like you put it, it's a great nature-nurture combination. It is important to also look at cases where things like these don't happen. Sometimes we hold on to, as psychologists I can tell you, we hold on to the untoward event, and our anxious mind also works in a certain sense in a way that untoward possibility, which is one of the probable possibilities, sometimes becomes certainty. That conversion of probability to certainty is what a concerned and anxious mind can also do, but it is a nature-nurture combination. Thank you so much for bringing that up. And I also know that this could be a very triggering conversation for a lot of people, just acknowledging that trigger is seen by some of us.
As a rainbow parent, we are often, barraged with questions by people requiring transition, etc. Currently, we are being asked by a person who has cerebral palsy whether they can transition, they want to become a woman. They have several disabilities. We are not even aware of many of them. Speech is one of them. And they are doing an online management course. They are entirely dependent on the family for their care. They are immobile. They are on a wheelchair, etc. So, what do we tell them?
Yeah. So, I work a lot with developmental disabilities, and when you look at cerebral palsy, there are multiple aspects that need to be considered. The gender transition is only one aspect. The physical extent of physical disability, cerebral palsy, is the second aspect. Third aspect is the intelligence and understanding level. So if they have an IQ which is borderline, whether they have the acumen to understand the implications of what they're going to undergo. They've heard about it, read about it, seen it on YouTube, and they've just thought, okay, let me do this. Or is it actually an inherent feeling that they have? If their speech is impaired, then they need to have someone who sits for long hours and try and understand and decipher what's in their mind so that this can be done. If they have a lack of speech, if they're using a communication board or a tool, or they're using a software, or they're using sign language, which also they can't because of the contractures. So someone needs to sit and first decipher what they're thinking. The other issue is that what are the implications of any physical treatments on their physical mobility and condition. It's not only about the gender change. So in such cases, what we normally say is transition at an external level could start first, and then a group of doctors evaluate, assess. But first we ascertain at the mental level also preparedness of the family, of the child, of the person who wants to undergo this, multiple things. So a lot of things change.
I would like like to ask a question.
Oh, yes.
Post-surgery, how does the person adjust with the society, with his parents, with his peer group? Is it very amicable, or is he, sometimes they are not at the same level, and they are still some may go into deep depression because they have not been accepted by, their peer group, parents. So I think that's a very, very crucial point in a person's life.
Yes. So 99% of the times it's non-amicable. Okay, it's only 1% of the times that, if they have a very good support system. So one of the things is that if they live in a small society, housing society, his close friends, the person undergoing change, I say his generally, the close friends, school friends, family, cousins need to first rally around him. People in the building need to be sensitized that this is going to happen. So they don't look at the person peculiarly, they don't comment. So acceptance first in his building has to come in a little, so that they accept. Because invitation to weddings, pujas, Ganpati will stop, very often. So first at a community level, that acceptance locally has to come in. We're not so worried about society now. First, at least where he stays. If he lives in a tower, like you have those Lodha towers and Oberoi towers, no one really bothers about anyone. So it doesn't matter much. They won't even know he came and went. But if he lives in this nice, what I call very beautiful, small housing society in Dadar, Matunga, like you see buildings around here, people have to know there because they observe it. And you have a lot of people who are sitting and observing what's happening in the building the whole day. So they know who comes and goes. So they need to, be aware. So that is something which is very important. So you have a society meeting and apprise people. This is this. Let the person who's undergoing change also tell the person that, auntie, uncle, I'm the same person that used to come to your house when I was small. I want to undergo this. Your love for me shouldn't change. I'm not going to be harmful to anyone. This is my personal transition. Multiple things have to be said. You will always have few people that don't accept. That's okay. But generally we find that when that sensitization is done, and it has to be done repeatedly. Because the community are like special children. You have to repeat again and again. When you repeat, then it goes into their head. So it has to sink in, like inception, I always say. So it will sink in slowly, but it will come.
I have seen a few cases who have committed suicide
Ma'am,
after the surgeries. Because still they haven't been, deep depression and then going into, is it detrimental?
No, so I will tell you this, that like she asked about, when we assess, we also have to rule out that this is gender related and not a body image issue which is leading to this, because many people have what we call body dysmorphic disorder, which is an abnormal condition. It's not gender dysphoria, it's very different. So we have to rule that out. So there are a lot of people who come to us and said that I've been bullied a lot as a boy, so I want to become a girl. I've been bullied a lot as a girl, so I want to become a boy. Now that's not the real reason why you should undergo transition. Do you want to actually become the opposite gender? Not to just escape these things. So there are multiple things. The assessment is not something that we finish in an hour. It can take 7-8 hours. We call them again and again, talk to them. It's not something that I just see you in 5 minutes and say, yes, no. Even with an amazing amount of expertise, it's not possible to do it fast. We have to take our own time and do it. Have some therapy sessions, speak to them, talk to them, trace back from their childhood the antecedents of what has led to all this multiple factors.
Thank you, sir, for addressing all the questions. Hello, myself Ansari Alisha B from Dr. BMN College of Home Science. I am pursuing human development. We would like to extend our heartfelt thank you to Dr. Avinash DeSousa for joining us in today's conference. Sir, we truly value your thoughtful and perspective, your shares, and the affirming way to address our queries. Your inclusive approach and dedication to mental health advocacy add the great insight and depth to our discussion. Thank you, sir, for sharing your personal experience, helping us to gain insight from medical point of view. Thank you, sir.
We'll take one last question and then we'll break for lunch.
Normally when they give you the bag, it means you won't go.
Good afternoon, everyone. So, Dr. DeSousa, it's always fun to, come for your sessions because you talk about sensitive topic with such ease, and it's so, and this is such a relevant
Say
topic.
that I'm also sensible.
You are, no doubt.
Right.
So my question for you is that you mentioned that you go for a lot of, sex education, classes for the teenagers, if I'm not wrong. Yeah.
6th standard to
Oh.
10th standard and 12th standard, yeah.
So I know how difficult it is at times to convince a school. I work in a school, I work with kids, even I take sex ed, sessions with them. So when it comes to, puberty, growing up, they're okay with it. But a lot of times, our kids are aware about because there are CDs, they're on social media, they know what it is. But sometimes half knowledge can be really dangerous. So how do you convince the school? At times, like I was able to convince my school, let's have this session. But when it comes to parents, there were few parents who had objected, why are we doing this? We don't want our kids to know about all this. Even though the kids were aware about it in some or the other form, the parents still, were resistant against the session. So how do we go about that?
Okay, so there are 2 or 3 approaches here. One is, I tell a few parents, you can sit in if you want, listen to what I'm saying and what they're saying. But the chances are your children won't ask anything if you're sitting. 2, I sometimes don't call it sex education because that's what turns away parents. I call it a personal safety program. And people like that term somehow, so, and I say we're going to protect your children from abuse and we're going to protect them from doing the wrong things. So I talk about sex education, sprinkle it with substance abuse, sprinkle it with other things. So we're going to teach them not to smoke and not to drink. Yes, please teach them, So then I teach them whatever I want, finally. So it's possible, it's manageable. It's not so change the term. Maybe the term is what, I even had a principal who said, can you conduct a program on suicide prevention but don't use the word suicide? I said, it's not possible. I said, I can't do sex education and not use the word sexuality. So I said, it has to be there. So you'll always face that problem. I mean, there'll always be some parents who say, we don't want to send our child. So I tell the children in the class, all that you learned, go and spread it. Tell people who didn't attend what it was. So they learn automatically. And today, we don't even have sex education like we used to have it. See, earlier, we used to have slides and other things. Today, what we do is, we put up 15 to 20 scenario questions, ask the audience to respond, to first gauge how much they know. Then on the basis of what they know, we conduct our session. So it's not done that, I go with a textbook and say, this is the male genital. They know all that. So it's, not at all. I mean, see, there's a joke that a parent went to a 15-year-old and said that we need to have a conversation about sexuality now that you're growing up. So the 15-year-old told the father, what do you want to know? Tell me. So that's the way. So, yeah. So that's the way it is.
Thank you very much.